Hi, so my name's Giselle Kidson-Gerber. I'm a haematologist. I'm based in Sydney at one of the large tertiary university teaching hospitals. And I look after a broad range of haematology, but I've always been interested in obstetric medicine. So I do a lot of obstetric haematology, and there are many overlaps. And I'm fortunate because I work on a campus which has the big adult hospital, but it also has a big women's hospital. So we share all our resources, all our imaging, or our laboratory pathology. And so we also share our patients. And I was motivated to write this paper because I saw some patients who had some bad outcomes, which I thought could have been improved. So some of the women were referred late, or they were cared by haematologists who are absolutely fantastic and have so much knowledge on the malignant side of things, but really very minimal experience on the pregnancy side of things. And there's such complex patients that you really need to understand both sides and to work out what the best thing is for the mother and for her unborn child. So anyway, I started gathering more information. I started presenting at meetings, and then I had a lot of people come up to me and said, you really should write this down because it'd be very useful to have it as a document. And so that was where the start of the paper began, and it blossomed from that. And the more we wrote the paper, the more we realized how much useful information we could put in it. So working a lot on the obstetric side, the multidisciplinary team is just so important, and everyone brings their different specialist view. So they have one perspective. So the obstetricians and the maternal fetal medicine, who are the specialist obstetricians, think about things differently to how I think about things, which is different to how the midwives and the clinical haematology nurses think about things, and the pharmacist and the imaging. So there's so many aspects. So part of the challenge was to make sure that all those aspects were covered. Often these papers are written just by the haematologist or just by the obstetrician, but I don't think that's the right thing for the patient because we need to have all the information there. So one of the challenges was getting the team. As I said, I have looked after a fair few of these patients, so part of the team was already in place, but we did need further expertise. That was one thing. Another challenge was there's so much to include. What do we include and what don't we include? We really wanted this to be a very practical position statement, that if someone who wasn't very familiar or hadn't seen a patient like this for a while had a patient, then they could pick it up and read through, and it'd really cover lots of different aspects. And there are references if they need fine details, or a certain subclass of lymphoma they might need to look into a bit more detail. We really wanted to have enough so that if a clinician had the paper, it would really help them have confidence to move forward. I guess one of the challenges was what to include and what not to include. And so there is probably more data than you'd realize. And so there was lots of data to put in, but there are some areas where there's not quite as much. And so putting some guidance in where it's helpful, particularly from an experience, but actually isn't as data backed as some of the other information that we have. I think nearly all of it would apply. In terms of the chemotherapy protocols, that's fairly straightforward, and we use protocols all from all around the world and share them all the time. So I think that's all there. In terms of how you manage pregnancy, that's also going to be applicable from Australia into America. I think the logistic issues are difficult, and it's not just in America where the problem might be. So even in other parts around Sydney and other major cities in Australia, they may not be co-located. So if you have a haematology unit and then the obstetric unit might be 10 minutes drive away, that's a big problem because the clinicians aren't used to working together. The communication isn't there, the pathology isn't there. You can't just see the latest temperature chart if the person's an inpatient or follow up as easily. And so I think that is a problem that's probably universal, and it's really something that needs to be addressed. So I think that's really important, and that's brought out in the guideline, how you work together as a team. And that's going to be the same. Look, some of the specialists might have slightly different names and terminology, but I think a lot of it is going to be applicable. So I think there's a couple of things to highlight. First is people like sort of at doctors as medical school, you say you never do any x-rays or imaging if someone's pregnant. But we have very good data to say that you can have exposures up, and you'll see the table in the paper of even up to 100 milligrave the fetus without significant impact. And so The reassuring thing here is we can do PET scans. So PET scans are really important in lymphoma at diagnosis to have accurate staging and then also to assess response to treatment. And particularly if you started with a slightly lower dose regimen like the ABVD because the woman's pregnant, it's really important to be able to evaluate her response. And PET scans, and more than one PET scan, can be safely performed in pregnancy. And I think that is really important. So we've gone to great lengths to put all the data and try and have some clear tables so that people can understand the safety of it and women and the clinicians can be reassured, and then they can have the test because that'll really impact their management. Another sort of information that's been around for a while, but I don't think everyone's familiar with it, is that if you look at the long-term outcomes of the offspring, so of the babies that are born, and one of the most important factors is their neurocognitive development, so how well their brain functions. The children who have poorer functioning brains are those who are born early. So we know from lots of data about prematurity at 26 weeks, 28 weeks, 30, 32, 34 weeks, those babies don't do as well from a brain development point of view and their long-term cognition compared to those who are born later. And there was a fantastic study comparing babies who are exposed to chemotherapy in pregnancy compared to babies who weren't exposed to chemotherapy in pregnancy, and they looked at the neurocognitive outcome, and the outcome didn't depend on whether they're exposed to chemotherapy or not. The outcome actually depended on the gestation in which they were born. And what that shows us is it's much better if a woman presents at 26 or 28 or even 32 weeks pregnant to give her 1 or 2 cycles of chemotherapy and delay the birth of the baby rather than quickly taking the baby out and then giving chemotherapy. Because if you think about the long term, obviously you want long-term female mother survivors, and we know the data is good on both sides, whether she was pregnant or not when she received the treatment, except if there are delays to do a termination or delays to have a birth, actually there is data in acute leukemia that those women do worse. So it's important that she gets the treatment. But also if you think about her partner, for example, he wants a healthy mother who's alive, but he also wants healthy children, and it's a double burden if you give him a sick partner to look after and also a sick child. And so it's just, I think one of the key messages is don't just quickly opt to a termination or a quick delivery, but actually it is safe to give particularly most conventional chemotherapy during pregnancy, and it's actually better for the baby to keep the baby inside and give the chemotherapy while the mother's still pregnant rather than delivering the baby early.